Welcome everyone. We are here today to discuss some of the fiscal, technical, and procedural challenges with implementation of the recommended HIV diagnostic algorithm and use of an instrument-based fourth-generation HIV immunoassay. Today we will discuss the algorithm rationale, hear perspectives from laboratory directors on challenges faced with implementation, and discuss resources available to laboratory administrators, directors, and relevant staff to assist in implementation of the recommended HIV diagnostic algorithm. Joining me now is Monica Parker, Director of the Bloodborne Viruses Laboratory at the Wadsworth Center.
Thank you, Thomas. I'm going to start today by reviewing some of the rationale for the new HIV testing algorithm. As we all know, accurate laboratory diagnosis of HIV is essential to identify persons who could benefit from treatment and to reduce HIV transmission. But there's never been a single laboratory test that is sufficient on its own to confirm HIV infection. Rather, laboratory diagnosis of HIV infection has always relied on a testing algorithm. That is, a set of tests that, when performed in sequence, provide the maximum sensitivity and specificity for detecting HIV infection. But we're here today to talk about a major update to the laboratory algorithm for HIV diagnostic testing. From 1989 until 2014, the CDC's recommended algorithm for laboratory diagnosis of HIV was to screen for antibodies using an enzyme immunoassay or rapid immunoassay, and then confirm reactive samples with either a Western blot or an indirect immunofluorescence assay, or IFA test. The Western blot and IFA were designed to be highly specific for verifying the presence of antibodies to HIV-1. However, it takes time for the body to mount a sufficient antibody response and produce a positive result on these confirmatory tests. Since the introduction of the first HIV enzyme immunoassays, we've seen many technological advances occur in the world of laboratory testing. Many of these were applied to HIV test methods, and in particular, the goal has been to reduce the window period between the onset of HIV infection and the time it can be detected by a laboratory test. Each new generation of HIV screening tests that emerged was more sensitive than the previous, but additional testing has always been needed using more specific methods to confirm a reactive screening result. However, the Western blot and IFA tests did not become more sensitive. In 2010, the first immunoassay capable of detecting both HIV-1 antigen and the HIV-1 and HIV-2 antibodies was approved by the FDA. These assays, known as fourth-generation HIV antigen antibody combo assays, gave us the ability to detect HIV infection during the acute phase before the body has produced antibodies. During the acute phase, the level of virus in the blood and body fluids is very high, and the risk of transmission is elevated. If someone seeks testing during this acute phase, it is particularly important to use tests that are sufficiently sensitive. Even before the fourth-generation screening tests were introduced, the problems with the Western blot were becoming apparent. Once the fourth-generation antigen antibody test could detect an acute HIV-1 infection before any antibodies were present, it was clear that a new strategy was needed. Furthermore, the screening tests were designed to detect HIV type 1, the most common form of HIV, and HIV type 2, a much less common form of the virus. And although FDA-approved Western blot tests were only designed to confirm antibodies to HIV-1, HIV-2 antibodies often cross-react with them. And although it is uncommon in the U.S., HIV type 2 does occur in the population, especially in New York State. The Western blot's been responsible for misclassifying many HIV-2 infections as HIV-1, and this has led to detrimental clinical consequences for these patients. For all of these reasons and more, the CDC released updated recommendations for HIV diagnostic testing performed by laboratories. In June 2014, the Centers of Disease Control and Prevention, together with the Association for Public Health Laboratories, released the updated recommendations for HIV diagnostic testing for serum and plasma specimens. The intent intention of these recommendations is that laboratories will produce a conclusive result regarding the presence or absence of HIV-1 or HIV-2 infection from a single diagnostic specimen. This may mean that in some cases, laboratories have to review their workflow and specimen collection and handling instructions. The fourth-generation antigen-antibody combo immunoassays have more stringent specimen handling requirements than some other assays that only detected antibodies, and the specimen may need to flow from a serology unit of the lab to a molecular testing unit to complete the algorithm. The combinations of test results may also be unfamiliar to some healthcare providers. It is important that laboratories be clear and consistent in the interpretation statements that appear on the lab report. There are also updated guidelines for public health reporting. Rather than relying on the result of a single Western blot test to identify a new case, it's now necessary to consider a combination of test results to identify a case. And laboratories have new responsibilities for public health reporting. Let's talk through some of the steps of the HIV testing algorithm. The recommended test to begin the testing algorithm is the HIV antigen-antibody combo assay. This is also known as the fourth-generation immunoassay. And the benefit of this assay, as I said, is that it will detect both the HIV-1p24 antigen and the antibodies to HIV-1 and HIV-2. And that means that it can detect HIV infection from the acute phase before antibodies are produced all the way through an established infection. And it can detect antibodies to both the most common form of HIV, HIV-1, and to a little less common but still important form, HIV-2. One thing to note about these tests, like all screening tests, they're not perfect, and there can be some false positive results. So in every case, you need to follow a reactive result on these tests with supplemental tests that are designed to be more specific. Another thing to note is that these laboratory-based tests, when they produce a reactive result, it's reactive, but you don't know whether that is because it detects the antigen, the antibodies to HIV-1, or the antibodies to HIV-2. And these are additional reasons why we need to do supplemental tests to sort through which of the analytes are being detected. And another thing I want to mention at this point is that regardless of whether you are using, this is your primary specimen that's being tested, or if you have first run a rapid test device and are now doing additional testing to confirm those rapid test results, we want to use the same algorithm beginning with the laboratory-based fourth generation test, the step 1 test. So if you get a reactive result on the step 1 test, the antigen-antibody immunoassay, you need to move on to step 2. Step 2 is an HIV-1, HIV-2 antibody differentiation test. This test is specifically designed to tell the difference between HIV-1 and HIV-2 antibodies. There are currently 2 FDA-approved tests that are suitable for this role in the algorithm. And both are designed to be very simple, single-use device tests, and they can produce a result within 30 minutes. If you get a result that is positive for either HIV-1 or HIV-2 antibodies, the testing is complete and that result can be reported a result. If the result is either negative or indeterminate for HIV-1 antibodies, then we need to go on to a third test, because that result could either be due to the presence of a very early or acute HIV-1 infection, or it could be due to the fact that there was a biologic false positive on your step 1 test. And so we need a third test to be able to tell the difference between those two. And so it's important to note that while we might think of this step 2 test, which we use to confirm the presence of antibodies, to be a direct replacement for the Western blot, it really doesn't function that way. We have to consider that the step 1 and step 2 tests have to be considered in combination. It is really a shift in thought in that we have to think about the combination of test results to get the final result of our algorithm, rather than relying on a single confirmatory test. Another important difference between the HIV-1, HIV-2 antibody differentiation test compared to the Western blot is it can be performed immediately after a step 1 test is reactive. There is no need to batch test, wait till you get enough samples to run a Western blot, and ideally can be performed on the same day as the step 1 test so that the turnaround time can be reduced and the client can get their results back more quickly. The result on the step 2 test is positive for either HIV-1 antibodies or HIV-2 antibodies. Testing is complete and that result can be reported back and the individual should be referred to care. If the result on step 2 is either non-reactive or it's indeterminate for HIV-1 antibodies, we need to go on to a third test. This test is an HIV-1 RNA test, and it should be one that has been approved for use in diagnosing HIV infection. The HIV-1 RNA test, if it is positive, would indicate that the individual was in an acute infection, and that should be reported back as positive and is likely to be an acute HIV-1 infection. If the HIV-1 RNA test is non-reactive, the overall interpretation is that there's no HIV infection present in that sample, and can be assumed that the initial reactive result was due to a biologic false positive. We recognize that certain aspects of these updated testing recommendations can pose challenges to laboratories. And in particular, we know that the HIV-1 RNA test can be a difficult piece for some laboratories to accommodate. One of the things that the Wadsworth Center can offer is to perform the HIV-1 RNA test for those laboratories that don't have either the ability to perform that in their own laboratory or have access to a laboratory, a reference laboratory, to do that for them.
Next, we will be hearing individual accounts from 2 laboratory directors on their journey through their implementation process. Joining me now are Dr. Daniel Amsterdam from Erie County Medical Center and School of Medicine, University at Buffalo, and Jack Wolk from Westchester County Public Health Laboratory. And I'd like to thank both of you for joining us today. We recently conducted a survey of laboratory directors and identified some key challenges to implementation of the new recommended HIV diagnostic algorithm. And I would just like to hear some of your own experiences with the implementation. Dr. Amsterdam, what was your laboratory's rationale for bringing on the 4th generation HIV-1, HIV-2 antigen antibody combo immunoassay and the recommended HIV diagnostic algorithm?
It was not a difficult decision to go forward with that. And the reason for that is that we were a full-service HIV laboratory. We were doing all of the elements for HIV testing, antibody testing, Western blot confirmation. And for a long time, both the CDC and New York State had promised that there would be some other laboratory test that would substitute for the Western blot, and its lack of sensitivity and its difficulty in execution. So it was not a difficult decision to move forward with the new algorithm, and we welcomed it. We compared, validated the assay, the multi-spot, with our Western blot, and found it perfectly acceptable, and we have it running now for approximately 3 years.
And Dr. Wolk, did you follow a similar rationale?
Well, our rationale is a little bit different from Dr. Amsterdam. As he mentioned, his is a full-service laboratory. The county public health lab was not doing amplification testing or viral load testing, but we certainly were doing screening testing and Western blot confirmation. Our rationale was that the vast majority of our samples are coming from the county public health department, from their walk-in STD clinic and their TB clinic. And we wanted to introduce the fourth generation assay because that walk-in population is a bit of a higher risk than the standard general population. So by incorporating the fourth generation assay and testing for P24 antigen, we were gaining additional sensitivity in that early diagnosis.
Yeah, I neglected to say, actually, Thomas, that we had experience early on in initial HIV antibody with the P24 component before it was changed. And we knew the advantage of earlier detection. And I think that's also is a key element in using the fourth generation, that the P24 affords anywhere from days to up to 2 weeks early detection of acute HIV infection. We actually had some of that experience in detecting patients who had acute HIV, who we subsequently learned that their third generation HIV would have been negative, whereas the fourth generation was in fact positive.
The other aspect for us, we are a significantly smaller lab with a lower volume of HIV screening than Dr. Amsterdam's lab. So to do a more labor-intensive method for confirmation like the Western blot was more difficult for us. So it was an easy choice to make once the multi-spot test became available to move in that direction, be able to do our testing quicker, easier, and less expensively.
And Dr. Amsterdam, did the HIV test volume and number of reactive results influence your laboratory's choice for use of the recommended HIV diagnostic algorithm?
Not really. Our choice was really based upon, as I mentioned before, the increased sensitivity of the assays, both in terms of early detection and the associated multi-spot with confirmation and capability to distinguish both HIV-1 and HIV-2.
Dr. Wolk, since your laboratory has a low volume of tested, this influenced your choice for the step 1 with the fourth generation HIV-1, HIV-2 antigen antibody immunoassay, as well as the recommended HIV diagnostic algorithm?
As far as the size of a laboratory, that in itself, in my opinion, shouldn't influence whether or not to implement the algorithm, but how you implement the algorithm. In our case, as a relatively low volume laboratory, we actually are doing our assay manually because of the number of tests. So we're doing our fourth generation ELISA manually, but certainly having a limited number of samples and a low number of staff, it made much more sense for us to be able to switch again to the multi-spot. So it's not so much that the size of your laboratory really should influence your decision to follow the algorithm, but the way you follow the algorithm. And then the other point that I would make is, unlike Dan's laboratory, where they are a full-service laboratory, because of our size, we're not able to offer the third step of the algorithm, the nucleic acid testing for HIV-1 and HIV-1 RNA. So we send that test out to the Wadsworth laboratory. So you don't have to offer all of that on site, but what you are able to offer is determined essentially by the characteristics of your lab.
I have a question for both of you now. How did your laboratories handle provider education for ordering of HIV diagnostic testing?
In our case, since I sit on the medical dental staff, I had direct contact with chiefs of service, and so we were able to have that discussion at that meeting. There's another type of meeting that I told them about my plan of implementation. And a big contributor in the HIV program at our institution comes from two directions. That comes from our ED and our HIV clinic, which we call our immunodeficiency clinic. So there were discussions with the principals in those areas about what we were going to do, and they all were on board with that. Additionally, I sent out informational notices to all providers.
And Dr. Wolk?
Actually, provider education really wasn't that difficult. Our situation's a bit unique. We have a limited number of providers working for the health department. Certainly, Dr. Amsterdam's lab has quite a larger number of providers from different backgrounds. Ours are all in public health, and so they were just as, many of them were just as familiar with the algorithm that the CDC was preparing as we were as laboratorians. So provider education really was very seamless.
Since it is a new algorithm, how did your laboratories handle the new interpretation of the results when they're provided to the providers or clinicians?
It wasn't difficult in our case because we were doing the Western blot, and this was simply another test modality that would incorporate that. The only difference with a confirmatory test like the multi-spot, it has the capability of differentiating HIV-1 and HIV-2. And if there was a question, then we would add a comment that the test might have to be sent out to determine if HIV-2 was present.
And Dr. Wolk?
We were already doing follow-up testing on reactive specimens with the Western blot, and so we would have appended comments in our report if there was a reactive ELISA result. The comment would already appear in the result that the specimen would be referred for additional testing. So for example, in the past, if we had an equivocal Western blot test, we would put a comment in the report that the specimen was being sent to the Wadsworth Center for further testing. And we kept that model in place when we implemented the multi-spot, so that any follow-up testing that would be done on the original sample, the testing that we could do in-house, like the multi-spot, would be done and included in that report. And then if the multi-spot was either an undifferentiated HIV infection or any other reason for NAT testing to be done, then the comment would be appended to the report that the specimen was being sent to Wadsworth for further testing.
So I have a follow-up with provider education. Did the provider education also include when and how to reflex to the NAT testing, the NAT testing?
Well, in our case, we have had reflex testing for reactive fourth-generation ELISAs in place already in doing our Western blot. So the provider was already used to knowing that by ordering the HIV, they would get any necessary follow-up testing automatically. So again, that was fairly seamless to them. The whole IT component of that was very seamless.
When we rolled out the new algorithm, we did include the fact that we would reflex to NAT. And I think that was welcomed by some providers because on occasion they would call and ask us to perform the test. But in the hospital situation, we have to get approval from the Medical Dental Executive Board to reflex automatically, which I was able to obtain. So that just became an automatic reflex within the lab. The specimens are there, or they could be obtained for NAT analysis.
So I have another question for both of you. There has been some confusion surrounding the fourth generation point of care test, and I'd just like to hear some comments from both of you regarding that.
I think it's a great addition to the technical armamentarium of tests that are available for HIV detection and diagnosis. In our setting, I'm principally opposed to a test like HIV being done in the point-of-care setting. And that's because typically you have non-laboratorians doing the test, and they don't have the mindset for the appropriate controls that are necessary to keep the qualitative aspects of a test in order.
Well, I certainly understand Dan's point, and I think it's well taken. In our case, our health department was already doing point-of-care test in their STD clinics and in their TB clinics. They were, up until very recently, using a third-generation rapid test. and they will be implementing, as soon as that test supply is exhausted, they will be implementing the 4th generation assay, the determine combo. So my bias, if you will, is that they are already screening because they have this high-risk population walking in, and they want to be able to counsel them immediately and make sure that testing is being done, rather than count on that patient coming back to clinic in a couple weeks. They don't want to lose those patients. So I certainly understand the health department's point of view in terms of offering a rapid. And if you're going to offer a rapid, I think it's good for them to be moving to the 4th generation assay, being a more sensitive, being able to pick up earlier diagnosis. Of course, the trade-off there, when you look at the specifications on the 4th generation rapid assay, is they will have a slightly increased risk of a false positive test. But that's sort of the nature of their testing. And again, this comes back to Dan's point. The providers may not understand that as well as the laboratorians do. So it's important there for the laboratory director of the point of care lab to make sure that the providers understand the limitations and benefits of the test that they're using.
And how do you feed in your point of care test into your core laboratory?
Well, again, since they are our primary client, most of the samples that are coming in for to be rolled into the algorithm, if you will, have already been pre-screened at the health department by a point of care test, up until now with a 3rd generation, and as they implement the determined combo, a 4th generation with the P24. And so that's already giving us a higher frequency of reactive samples coming in, because if the rapid test is negative, they generally don't do any further testing. The exception being if they are concerned about or wanting to rule out acute HIV infection, they sometimes do refer specimens directly to Wadsworth for NAT testing. So hopefully that answered your question in terms of these are feeding in. We are, I will mention, we are hoping to get one other client on board who's looking for more rapid turnaround time than they're getting from their current laboratory. And so we're looking at potentially offering the determine in our laboratory as a way of doing an initial screen, and then those reactives have to be have a 4th generation immunoassay, ELISA, performed on them. So the determine can't serve as the first step, and that's the point I think that confuses people and that I want to clarify, is that the determine assay can't serve as the first step of the algorithm, but you can refer specimens that are positive with the determine into the algorithm and begin your normal algorithm with the 4th generation ELISA test.
Dr. Amsterdam, how did your laboratory prepare for some of the IT updates associated with the new immunoassays and instruments and the recommended HIV diagnostic algorithm?
There was no real effort or build involved, since both the initial testing and the confirmation was there, plus the component of reporting positives to New York State via the ACLAIR system. So there was no additional effort on our part. I could see there might be additional effort if an individual laboratory did not have the confirmatory test in place.
What issues do you foresee if they didn't have the confirmatory test in place prior?
Well, it's the challenge we all face in dealing with IT. There is consternation in getting things done, and that will play out. The laboratorian with the chief medical officer has to make that plea that IT helps in the building of that component.
And Dr. Wolk?
Well, like Dr. Amsterdam's lab, we had confirmatory testing in place. The reflex was already built in the laboratory information system. So again, that part of it was easier for us than a lab that's not already doing confirmatory testing and would have to build the reflex testing. All we really had to do is our health department is interfaced through a bidirectional interface from their electronic medical record to our lab information system. So we wanted to make it very seamless for the provider when they were doing electronic test order entry. They had their test code on their side didn't even change. When we went live, we just pointed their test code in the data tables to the new test for the multi-spot and the rest of that algorithm, and discontinued having it point to the Western blot portion of confirmatory testing. So it was really like flipping a switch. We just had to coordinate it. We temporarily disabled the Western blot part of that reflex in order to do the testing, and we made sure that that occurred on a day when the clinic wasn't actually sending tests and that we weren't performing them, so that samples weren't misdirected. And then as soon as the testing was done, turned it back, flipped the switch back until we were ready to actually live test with the multi-spot. So we kept it, the challenges we kept all on our side and kept it relatively seamless for the providers.
Another consistent challenge that was generated during the survey with the laboratory directors revolved around both cost, billing, and reimbursement. What has been your laboratory's experience dealing with both the cost, billing, and reimbursement with the new HIV diagnostic algorithm?
Want to handle that first?
Well, I can handle that first because as a public health laboratory, we don't charge patients. We are reimbursed by the state. We receive some state aid for our HIV testing, but we don't get involved with fee-for-service testing and third-party payers. So that component of it really was not a major factor for us, but certainly the cost aspect. And in fact, because we're not getting reimbursement other than some state aid, we certainly have to keep an eye on our expenses the way we do our tests. And certainly that's the #1 reason why we're not able to offer the nucleic acid amplification testing. It just is not cost feasible for us. So the cost side of it is important for us, but not so much the reimbursement. That doesn't affect our laboratory.
For us, all the patients that we perform HIV, I shouldn't say all, I would say 99% are non-bedded. So they don't come under DRGs. They all can be charged, or their insurance companies charge for whatever tests that we do. And we usually do receive reimbursement through New York State Medicaid or the particular insurance that the patient has. So the issue of bringing on a new test has never been a problem related to HIV. It's a cost that has always been taken up by some third party. And although the charge master, which is the official pricing in the hospital, it doesn't necessarily match the reimbursement, charge masters never reflect the reimbursement.
Well, I'd like to thank you both for sharing your own experiences with implementation of the HIV diagnostic algorithm.
Welcome.
I would now like to mention our toolkit as well. We have compiled several resources, including the CDC and New York State documents and reimbursement information into a central toolkit available online. The link will be listed at the end of this presentation. I would also like to thank everyone for joining us to hear about some of the challenges to implementation of the algorithm. And if you have any questions from today's talk, please send them to the BML listed at the bottom of the screen. Thank you.